All right, welcome back, everyone. We hope that you've had a chance to network. Hope you got a lot out of the breakout sessions. This is it. This is the final session of this year's AvaSure Symposium. And it has been amazing. It's gone fast, and we've packed a lot in. But stay with us because this is the grand finale. One of the most troubling developments of the past several years in healthcare has been a sharp rise in the violence against nurses and other staff. Fed by things like the opioid epidemic and the rise of behavioral health disorders, nurses are increasingly subject to verbal and physical abuse. Our final session of the symposium, Case Closed, Remote Video Monitoring Increases Staff Safety, reveals how the telesitter has become a vital tool in protecting nurses and other staff. Our presenters are Lisbeth Vatruba, Chief Clinical Innovation Officer at AvaSure, and Christina Case, Clinical Manager, Providence St. Peter Hospital. Lisbeth?
All right, thanks so much, Andy. I think we probably all heard the statistics out of OSHA that healthcare workers are 4 times more likely to be injured in a violent event than non-healthcare workers. And I have the opportunity to talk to nurse leaders and healthcare leaders in my job. And I don't think I've ever had anyone say, well, that's, not really important to us and they can fend for themselves. So everybody says this is a priority, this is important, but sometimes it feels like maybe it's a priority on paper, and not really, things aren't really implemented. And I think part of the struggle is that it's underreported and leaders aren't exactly sure how to tackle it. And so I'm really honored to co-present today with Christina Case from St. Peter Providence Hospital. So they said it's a priority. And then they also said, we're going to create a toolkit. And then they also implemented the toolkit. And then they measured the outcomes and the impact of that toolkit. And this is the kicker, they published it in 2021 in the Nursing Forum. And I don't know who has the time to publish. I don't think anybody does have the time, but Christina made the time, or Christy, as she likes to be called by her friends, now that we're friends. So I'm really excited to hear about what St. Peter Providence is doing, and I think step one really to impacting this issue in healthcare is measuring it. And so after Christy shares, then I'm going to share a little bit. We're going to pull it up to the 30,000 foot view and share data from over 200 hospitals across 4 years from our online reporting of nursing analytics database, describing what monitoring staff members have seen across the country of over 1,000 physical and verbal abuse events, and more importantly, 17,000 that they prevented. And so we're analyzing that a little bit, finding patterns and making improvements one step at a time. So I'm going to start by turning it over to Christy and letting her share about St. Peter Providence, 5 items in their toolkit. It's called the STARS toolkit. And a little spoiler alert, telesending is one of the tools that they've used. So go ahead, Christy, tell us about your program there.
All right, thank you, Lisbeth. I'm very excited to be here. So our toolkit is called the STARS Interventions for Violence Reduction, and STARS stands for Safety, Technology, Activity, Relief, and Surroundings. And the T stands for technology, and the most important part of that technology is the AvaSure remote video monitoring device, which we use to prevent violence against our staff and also preserve the safety of our patients. So we did this quality improvement project focusing on patients who are needing continuous observation, and I kind of use the term continuous observation interchangeably with one-to-ones or sitters, so I mean the same thing when I say those things. And these patients are often risk for violence patients. There are CNAs generally who are sitting with them one-on-one, providing continuous observation and care. And these CNAs do not have behavioral health expertise. So they struggle to manage the behavior of these violent patients with just the skills that they have. And this was very concerning to us. We want to make this a safe place for our caregivers. We want to retain our staff. And there's really a gap in knowledge concerning the effective interventions to reduce patient violence when you have limited psychiatric resources, which we have at our hospital. We would have loved to have had a behavioral health rounding team, but we did not have access to that. So we tried our best to make do with the resources that we had to kind of patchwork together what could support returning these patients to baseline as soon as possible. So the STARS project set out to attempt to improve one-to-one continuous observation patient care and reduce violence against staff by using the resources that we had available and trialing whether rounding by a nurse leader on these patients regularly might be helpful in reducing violence and the need for continuous observation. So the purpose of the project was to trial structured nurse leader rounding on all of these patients and staff that were requiring a one-to-one sitter. And we tried, when we were doing these roundings, we would engage the patient, we would engage the staff. When we implemented this, it was back when we could have visitors. And so we would engage the family, and we would all brainstorm and try to improve the care for this patient, and also try to preserve the safety of the staff that were caring for these patients. Because of the violence that the patients often exhibit towards staff due to their confusion or cognitive deficits, we were hoping to improve the continuous observation staff's feeling of safety while providing one-to-one care. We were hoping to improve assault reporting through education when we were rounding, and we were also hoping to reduce the need for one-to-one continuous observation hours. So our description of the STARS interventions: a nurse leader, and that would be an assistant nurse manager, or a charge nurse, would round in person on the patients that were requiring a one-to-one sitter. Our most important question, and the one that I would always start with, is, were there any violent events with this patient last night? Are you feeling safe caring for this patient? If the answer was yes, there was violence, and no, I'm not feeling safe, I would check to see if there was a remote video monitoring device in the room. If not, this would be the first thing that I would implement to improve the safety for that staff and the patient. We provided assault reporting education, and the monitor techs also, when the device was in the room, were another witness to anything that might happen violence-wise in the room. We reinforced holistic care for the patient, and this would mean, looking to see if the patient is comfortable, asking, are they constipated? How are they eating? Are they bored? Do they need some activities? We had, cards or colors or things like that. And we engaged the whole care team in troubleshooting behavioral challenges. We also, in the beginning of the project, I had the opportunity to work with a pharmacy resident, and she rounded with me, and for every patient round, she would review their medications and the psych meds, pain meds, bowel meds. And it was kind of interesting how important the bowel meds are. So do not underestimate the power of bowel medications. She was with me for 128 rounds, and we did this over a 6-month period. And we engaged the care team, the patient, the staff, and the family for a total of 931 rounds over that period. So a little bit about Providence St. Peter Hospital and our remote video monitoring program. We started using the AvaSure remote video monitoring devices in 2017, and we started with 20 devices, and it quickly grew, and now we have, I believe, 60 cameras. We are the hub for the Southwest region, and so our patient monitor techs are watching patients and staff, keeping them safe in 4 different hospitals. The training for our monitor techs includes online modules, and then they also have in-person hands-on training where they have a preceptor monitor tech who's showing them how the job is done and sitting beside them as they're providing interventions through the images that they're seeing. And we have a very special thing to show you today. This is a story from our wonderful patient monitor technician lead. Her name is Deanna, and she is one of our day shift patient monitor tech leads, and she is going to share her experience.
I'm a day shift telesitter lead at Providence St. Peter's Hospital, Olympia, Washington. I am responsible for the telesitter program and all of the other employees that work there. Our main role is for staff safety at our hospital. There have been a lot of violent patients. I do see a correlation between COVID and violent patients. I think it's harder for people with mental health struggles be able to get their appropriate medication or see the right doctor. And a lot of walk-in clinics and areas that might be resources for those individuals in general keep telling them, oh, go to the emergency room. A few months ago, we admitted a male patient at Cadillac for violence and elopement and aggression. He came on with some history of bipolar and schizophrenia tendencies. He was just pacing back and forth, and I started notifying staff, hey, you know, he's starting to get sort of amped up. He just slammed the ER door to where it was very traumatic. Being in the ER, they have a lot of individuals there to help and step in, but unfortunately he was able to get out of their grasp and punch a physician. We have a no violence policy there, and the telesitter makes it possible for us to get help immediately. Being able to notify staff the triggers that I was talking about, the things that can lead up to violent behavior, pacing or throwing things. It was crucial for the telesitter to be able to see what was happening so we could notify staff. We just called security, we called the RN. It was one of the biggest takedowns we had seen personally. It was like 14 people to restrain him. We were able to help to try to, you know, prevent what we could. We're taught throughout healthcare endlessly that, you know, oh, we can take a beating. Working at Providence, it was the first place I'd ever worked at where I felt like they cared about me. Having the telesitter there, it's really changing lives, not only for staff, but for most important, our patients. We wouldn't be here if we weren't compassionate souls that are trying to help others, and being able to just have that resource, it's amazing. And I'm so lucky to be a part of it. We get to do it and see it and breathe it and love it.
So as you can see, Deanna is very passionate about her job, and we are just so glad to have her here watching out for our staff and our patients.
I asked you yesterday, Christy, is she going to nursing school?
And the answer is yes. Yes, she is.
She's going to be awesome.
Yes, she will. She definitely will. So I'm going to switch gears a little bit now and just talk about the educational packet that we would provide when we would do the rounding and a few of the items within that packet. The first page was the STARS interventions handout that had just some quick bullets that the one-to-one sitter should keep in mind as they're caring for the patient, meaning that holistic care that we were talking about. We created a really good violence prevention tips sheet with information on assault reporting, and that's when we would talk about assault reporting. If a one-to-one caregiver was assaulted, we would walk them through that, ask, well, did they report the assault? And if they had any questions about reporting the assault, we would guide them through that. Also within the packet was a guide for the family caregiver, because a lot of times when your loved one is confused in the hospital, you're visiting them, you're kind of at a loss for how do I help here? So we listed out some good ideas that the family members could do while they're in the hospital with their loved one. And then 2 forms that we had within the packet that have been very useful, and we're using them a lot. The Get to Know Me form, which is a paper that has some bubbles and a picture of a patient's face. And it says, you know, these are things that are important to me. And the one-to-one sitter or the family member or the patient, if they're able, could fill that out. These are important things to me. These are people that I'm connected with, that I love. These are pets that I have. This was my job or is my job. These are foods that I like. These are foods that I don't like. And we put that right up on the whiteboard. We just tape it to the whiteboard. And that means that anyone just coming into the room, if they see that sign, they can see those individualized facts about the patient, and they can start off on the right foot talking about the patient's cat Fluffy or their early life on the farm or whatever it is that would start out a positive conversation with that patient. We also have the behavioral handoff report, which is a one sheet report. It's passed from one staff member to the other staff member, and it has prompts such as the problem behaviors that a patient is exhibiting that people should look out for, the triggers that might prompt those behaviors, effective de-escalation techniques that that staff member has learned about the patient throughout their shift. And so this is a way that when, you know, a caregiver spends 12 hours with a patient, they really learn a lot about that patient. Well, the next caregiver comes along and all of that might be lost, but this is a good way to hand over that knowledge to keep consistency of care from one caregiver to the other. So at the 6-month mark of our implementation, we sent out a survey to see what, you know, if the CNAs liked the STARS project, if they felt that it was effective. We sent it out to 150, all of our acute care CNAs. We ended up getting 46 responses, and of the 46, 20 of them had been rounded on more than once by a nurse leader talking about the STARS project. And math, I didn't prepare that part. I know there was 20 in the best group. And then you could go to the next slide and I will talk about it. Okay, so this is kind of a complicated graph, so bear with me. So the green bars, that is my group of 20 CNAs. These are the CNAs who experienced the STARS project, the way that it was intended. If we had, you know, all of our managers, all of our charge nurses rounding on our one-to-one staff, day shift and night shift, for every single shift, this is what they would have experienced. Consistent, repeated nurse leader rounding to support their safety. And so these were questions that we asked, the 4 main metrics that we asked. The first question was, I feel safer. Do you feel safer in a one-to-one because of the STARS project? And you can see in the other 2 groups, the blue group are CNAs that saw the STARS educational packet. Maybe they used the forms, maybe they read through it, but they never experienced a STARS nurse leader round. The orange group were CNAs who experienced a nurse leader round one time, introducing them to the STARS project, explaining the packet, and providing that follow through for them. And then again, like I said, the green group, the group of 20, got 2 or more STARS nurse leader rounds. So the first question was, do you feel safer in a one-to-one because of the STARS project? And you'll see that over half of them, even in the group that never experienced a round, did feel safer because of the STARS project. And the more nurse leader rounding that they experienced, the more likely they were to answer, yes, I feel safer. And I just want to reemphasize that one of the most important interventions that this nurse leader rounding had was asking them if they felt safe, asking them if the patient was violent, and then recommending that remote video monitoring device if it wasn't already in the room, if the answers were yes to those questions. The second question on the survey, do they feel that STARS has reduced violence? And you can see that in the group, the wonderful green group, 90% felt that STARS had reduced violence. Next question was, do you feel that STARS has brought attention to the sitter role? So this was the way I was trying to phrase a question to measure their engagement. And 100% felt that 100% in the group of 20 that experienced 2 or more nurse leader rounds felt that it had brought attention to their very important role that they're providing for the patients. The last question, did they feel that the STARS project had improved one-to-one patient care? And again, in the group of 20, 100% felt that. So you can see that the STARS project was well received by the CNAs, and the more in-person nurse leader rounding that they experienced, the more effective that they believed that it was. And these were a couple of quotes from some one-to-one sitters that we had a place for free text on the survey, and we actually got quite a few comments, but these were a sample of them. One CNA said, "I've seen improved planning for potential events and better support when a patient becomes unsafe." And another said, "I feel much more supported as an employee instead of being stuck in an abusive patient's room without support." And I just want to stop there and just share a little experience that I had very recently. I was breaking a one-to-one, so I was in the room with a patient. She was a patient with dementia and a broken hip, and she was a violent patient, and she really, really, really wanted to get out of bed. And she was wiggling, and I was trying to hold her in bed, and she was getting so mad at me because I was blocking her from falling out of bed, which of course I didn't want her to fall out of bed. She started grabbing at me, and I thought to myself, okay, the door is closed because, we wanted her to go to sleep. That's because it was in the evening. It was actually 10:30 or 11 at night. We wanted her to go to sleep. The door is closed, and I'm thinking, if I move to hit the call light, she's gonna fall out of bed. And then I heard the magical voice of the patient monitor tech, because there was a camera in the room, and I hadn't even been thinking about that at the time. But the patient monitor tech said, "Do you need some help?" I was like, yes, I do. And I was just so grateful for that. And so I'm well aware what the CNAs experience when they're struggling with a patient, and they do have that remote video monitor tech device support for them. So we did see an increase in assault reporting, and this is kind of tricky because, this is our number of assaults. The orange is the assaults without injury, and the blue were the assaults with injury. And this was our total assault reporting, not just with our one-to-one patients. But what we were trying to do is, because like Lizbeth said, the assaults are chronically underreported in hospitals, and this is well documented because we have kind of a historic culture of just taking a beating, and we don't want that to be our culture. We want our caregivers to feel like they should not be assaulted. It's not acceptable, and if it does happen, despite all of our efforts for it not to happen, we want it to be out of the norm. We want it to be reportable. We want them to feel like it's worth the effort to go ahead and report that. So although this looks like an increase in assaults, it was actually, we're hoping, an increase in assault reporting. And as you can see, the assaults without injury increased at a greater rate than the assaults with injury, which also kind of supports that. And so we're hoping that this intervention, this toolkit, actually had a good effect on the culture, and more people are going to be reporting assaults. We had a disappointing result for our trying to decrease the continuous observation one-to-one hours. They held steady, so we did not see that result that we were hoping for. But we did see a very surprising and very, very heartwarming response from the staff with this toolkit, with this rounding. So although we didn't see a decrease in the one-to-one hours, I really feel like the payoff was in the feeling of staff safety and engagement. So our key points are structured nurse leader rounding on one-to-one continuous observation, patients, families, and staff using our STARS educational toolkit and incorporating the use of the remote video monitoring device for patients at risk for violence. It improved the staff's feeling of safety and engagement, and it increased our assault reporting at our hospital, and it did not reduce continuous observation hours. So the recommendations for practice change after this project are to incorporate structured nurse leader rounding on one-to-one continuous observation patients and staff using the STARS educational toolkit, and also for any patients with a risk of violence, whether they need one-to-one staff or not, consider that remote video monitoring device because it can definitely help staff feel safer and be safer. So thank you very much for listening today, and I'm going to turn it back over to Elizabeth, who is going to share from her perspective her 30,000-foot view.
Thank you so much, Christy. That was very, very powerful. And I've watched Deanna's video a few times, and a couple things pop out at me about it. One is how she describes herself as a compassionate soul. And just to have someone like that who is behind the device and interacting with your patients is so powerful. Another thing is she said, at Providence, I feel like they care about me. And so your charts and graphs are amazing, and you look at those green bars and you see the 100% and you think that's great. But in that bar is are employees like Deanna, who said, I feel like Providence cares about me, and are engaged. And so and you see her smile at the end of the video, like she just loves her job and she's going to nursing school. So really great. And I think a theme that we've heard from other presenters and monitoring staff as well is that those really high level exceptional monitoring staff members are watching for those precursors. And I heard her say that too. She saw pacing. She had told us, I think not in the video, but that throwing objects, slamming the door, these are all precursors. And somebody earlier today said, get off the train tracks if a freight train is coming. And that's what they tell their staff. I think that was Benefice Hospital, about being prepared for those potentially violent patients. And as a nurse, we all as nurses have a duty to share knowledge that we gain that improves patient safety or staff safety. And this is actually based on the ANA Code of Ethics for Nursing. And so we take that very seriously. We have, I think, 26 nurses here at AvaSure. And so that's why we share our ORNA data publicly, because I think it can help. It can help guide progress. And so that's what we're going to do today. And keep your fingers crossed, because Christy and I submitted this as an abstract to AONL, and we hope to present this at an even larger audience in the spring. So I'm going to start with my PowerPoint now. And I'm going to go backwards one. Okay, so we were able to look at the data for the last 4 years, and our hospitals, there were 195 that reported at least one abusive event. And so we had over 1,000 abusive events and about 1,000 abusive patients. Some of those patients were abusive more than once. But 17,000 abusive events prevented. So I'm going to channel our friend Pat Quigley, because Dr. Pat Quigley right now would say, friends, is that a wow? She would call that a wow factor. I think that's a wow factor too. So monitoring staff are able to intervene like happened. So you illustrated it so graphically. It happened to you just a few days ago. That would have been in one of those 17,000 events that were prevented. So I'm going to talk about our method. So monitoring staff are able, when they observe an abusive event, they have small 500 characters to describe what they saw, verbal or physical abuse. And many of you may be aware that we published, Dr. Pat Quigley, Joe Kaminsky, and I, in the Journal of Nursing Care Quality. And it came out in 2020, so the data collection was prior to that, 2019, at about 300 abusive events. So we used some of the same analysis with the guidance of Dr. Quigley, who's a nurse scientist, qualitative analysis. And here are some of the physical abuse categories. And I'm giving examples of exact examples of what monitoring staff documented and observed, and then how we put those into categories. So physical contact is pretty straightforward, and that there's some kind of physical contact between the patient and the caregiver. So that will be categories really in our top category there. And then combative happens a lot. The patient was kicking at or punching towards, but didn't quite make a connection. So that's the combative event. And then we get down to some of those precursors. Spitting and biting and throwing objects are things that we have seen very often documented. And then on the verbal abuse categories, profane language being used, that happens a lot, and threats, in death threats. This I know would have a profound effect on me as a nurse or caregiver, but not necessarily. I have Wendy's in the room with me here. She's an emergency room nurse, and I think she probably didn't fill out an incident report every time that somebody swore at you. You would not have time for that, but a monitoring staff does it. And then the intimidation and yelling. And then one that's very disturbing is name calling and derogatory remarks. And I think when I became a nurse in the 90s up until now, we've made some progress on really not tolerating that and addressing and protecting staff when patients are inappropriate in that way. And so we took those categories and you'll see that physical contact was the most often of the physical abuse, and profane language the most common of the verbal abuse incidents. But and part of our method was that in that descriptor, sometimes they would say that patient screamed at the nurse and then punched the nurse in the arm. So we would elevate that to the abuse category at the highest level. So that explains part of the reason why there are less verbal incidents than physical incidents, because we just took the most severe incident described and put it in that category. As well as those of you who are familiar with the devices would know that monitoring staff don't hear every patient all the time. So they're monitoring 12 patients. They only listen to one at a time, so they might not hear all the verbal incidents, or they themselves might be biased against taking the time to even document verbal incidents because they're so common. And I think the other important thing to note here is the physical contact. There's a subcategory of there where injury occurs. And so the subcategory, the physical contact where an injury occurs, is probably the only thing that historically gets reported to human resources. But I want you to think about that's just a slice of one of these bars and how much bigger the whole picture is. And that's part of the underreporting that's happening. And then this just demonstrates that since 2018, when we've started to capture physical and verbal abuse events, 2017 actually, that has been on the rise quarter over quarter. And this is not perfect data analytics. We have more work to do, which we'll probably do before we do AONL, because we've had more customers too. So the baseline has elevated as well, but it seems to have an increasing trend. And then here's something really interesting that we noticed in the data that I'd like to share today. So on the x-axis is quarter over quarter data, starting with 2016 up to the first quarter of 2021. The y-axis is the number of patients that aggressive or violence occurred. This is the number of patients who are being monitored for this reason. So the nurse gave handoff report to the monitoring staff. I want you to watch this patient. I'm concerned they might be violent. And then staff injury or violent aggression is checked off in the in the admission process on the software. And so you'll see that goes from 0 to 2000, and that has been increasing over time. But the colors are important. So the teal is the patients that are being monitored as the primary reason, and the orange is the secondary reason. So most of these patients are primarily being watched for something else, and I'll tell you it's probably false. Like Christy's patient, this is an Alzheimer patient. She has a hip fracture. We don't want her to fall. We're watching her primarily for fall prevention, and oh, by the way, she might be violent. So it's secondary. It's an afterthought, is what it is. And just for comparison, we did the same analysis on the suicide risk patients that have been monitored. Same graph format from 2016 to 2021. The y-axis has a much bigger range because a lot more patients are being monitored for suicide risk than for workplace violence. It goes from 0 to 4,000 patients each quarter. But that's the primary reason, and rarely is it a secondary reason. So I just thought this was a colorful and good example, visual example of how it's can be kind of an afterthought. So I guess in conclusion, I think any good research or any good presentation that's done, the presenter should admit that there's more research that needs to be done. And those of you that were able to attend that just inspiring presentation that we started with today, John O'Leary said, "We are not done." And we are not done here. I think we have some really great ideas that we're working on, but we're hoping to inspire those of you who might be participating today to do some research on this. Patient selection, really, we don't actually know how to do that. Like, it's an Alzheimer's patient. It's not clear necessarily, except for patients that may have had a history. And the impact of monitor and staff training, and we kind of alluded to some of that monitoring staff that are able to anticipate the escalation is really important. But from our 30,000 view, we don't know exactly what amount of training has been done, and I'm sure it varies. And then and just the increased awareness for bedside staff. Hey, I can use this. I don't have to just use this for falls. I can use this for this other idea. And it looks like some questions coming in. So I think we'll cover some questions, but I'm first going to start with a question that got posed to me last Thursday from a nurse leader on the East Coast, a nurse manager. And she said to me, we were talking about this, they're really struggling. And she said to me, do you mean to say that staff safety is more important than patient safety? And I did not do well. I didn't answer that well. I was just kind of stunned, and I was a lame answer. Whatever I said was something like, I'm not sure. And and then it was one of those things, and it was a question from her heart. She was like, how can you say that staff safety is so important? And I went over that conversation in my head, and actually 2 hours later, Christy and I had our prep conversation, and I was talking to Christy about this, and you had a much better answer than I did for that nurse manager. Do you want to kind of share what we talked about a little bit, and how your CNO talks about this at St. Peter's?
Sure. So when I am rounding with the one-to-one continuous observation sitters, I tell them, patient safety, of course, is very, very important to us, but it is not at the expense of your safety, not at the expense of staff safety. And our CNO gave us all a book for Christmas, and it's called Patients Come Second. And the first chapter pretty much is kind of dealing with the shock value of that title. But the premise is, we need to take care of our staff in order to preserve patient safety. If staff aren't feeling safe, if they're leaving in droves because they're getting, hit, threatened, and everything, and we can't keep CNAs around to keep the patients safe, the patients aren't going to be safe. So that would be my answer.
Yeah, that's a really good thought. And the more I thought about it, I remembered my very first CPR class. What is the first thing they tell you, or it might have been ACLS or something? First thing they tell you is survey the scene and make sure that you're safe. Like, don't run out into traffic to try to rescue someone, or electrical wire down or something. Y- Absolutely, it is. You do have to keep yourself safe, and that was another thing that John O'Leary, our speaker this morning, talked about, caring for ourselves. How do we care for ourselves first? And so I think that was kind of an overarching theme for these last couple of days. So a couple questions. Do you use telesitter and one-on-one at the same time, or do you replace a sitter with a telesitter, or you call them continuous observers with video monitoring? And if you can speak to it, and I can maybe talk about what I've heard elsewhere.
Yeah, absolutely. So, as the patient kind of goes through their hospital stay, they're going to have a spectrum of behaviors, and hopefully their behaviors are getting better. And so, the answer to your question is both. We do both at different times and for different needs for patients and for staff. So, if there's a violent patient who is needing continuous observation, so they have a one-to-one sitter, we would place a remote video monitoring device in that room to help preserve both the staff and the patient safety. And then as the patient gets better and maybe doesn't need that sitter anymore, the sitter won't be there all the time, but there will still be staff coming into the room and caring for that patient. The device would stay in the room and keep providing safety for the staff and the patient, because the patient is likely to may be violent again during a brief change, but maybe they don't need to have someone watching them all the time anymore.
And that's kind of what I think earlier. Benefice hospitals said they rarely use sitters at all for violent patients, and so that kind of varies. Sometimes they need to be doubled up, and sometimes you really don't need to put a sitter in harm's way at all. And then this is kind of a follow-up question on that. One of the fears is having the device with a potentially violent, is that the device will be used to attack staff. Is this a legitimate concern? Has that happened in your experience?
To my knowledge, we've never had a patient use the device to attack staff. I think one time we had a patient knock the device down, and that was intentional. He was having a violent episode, and he took it and he slammed it down, and he did damage the device. But that's the only time, and we use these devices a lot.
Yeah, and I kind of think of it too, that I would much rather have that happen to the device than a nursing student or CNA who is in physically sitting with. So you'd rather have the device damaged than the staff member.
Absolutely, yeah.
And then, did you survey patients and families about their experience with stars?
I did not do that yet. Nope. The only survey that we did was for the CNAs, the sitters, but definitely I did talk to a lot of families, and so it was kind of an informal survey, and they loved it. I mean, when we would come around with them, provide that holistic care, it was good to talk to the families about the need for the device in the room, and they were receptive that a nurse leader was coming in and supporting the use of that device and why it's needed for their loved ones. So yeah, they were receptive to that, but that would be an area for further research.
Yes. Yeah. Throw that right back out to the audience. Okay. I think one of the themes for today is gratitude. So I want to express gratitude to you, Christy. I know when we talked last week, you were extremely short staffed and you just still carved out time to share this with us. We really appreciate that. And then also, a heartfelt thank you to all the caregivers and leaders, all that are participating, have participated today to take time to be with us. And lastly, I'd just like to thank the AvaSure staff, the marketing staff that put this together. Such a great symposium with just rich content. It just gets better and better every year. So thank you, Laura Melendez, Allie Jewett, and Kate Gorski from our marketing team, and the nurses here who help recruit some really amazing panelists. So I'm going to close with gratitude. Thank you.
And thank you, Lisbeth, for all you do and for leading that last discussion. It was fantastic. I want to thank all the attendees for joining us today. We've come to the end of the program. A couple of reminders for you. An email will be sent out next week with a link to the recordings and a survey. Please, 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 please take time, fill out the survey. Your feedback is really important, so we can build on this symposium and continue to make it better and better each year. Visit our website at avasure.com for additional resources like our clinical evidence index and our information blog. And for upcoming events and presentation, visit avasure.com events page. That's it. We made it 2 days, jam-packed with great information, great content, great presentations, and you. Thank you very much, and enjoy the rest of your day.